Hi everyone. So I am Lucy and I am a senior data scientist at the NHS Business Services Authority. Okay, not going to dwell on this, but just for anybody who isn't familiar with who the NHS BSA are, we are an arm's length body of the Department of Health and Social Care, and we deliver a range of national services to support primary care, NHS workforce and UK citizens. And our platforms, systems, services touch countless of lives, and we facilitate the flow of around £100 billion of NHS funds every year. And I don't want to dwell and go into what all of our services are, but I do want to highlight one of them, which is that we reimburse pharmacies for prescriptions that they dispense. And in doing so, we create and retain this really rich, wonderful data set of all NHS primary care prescribing. And this is the data set that EPAC2 sits on, that Open Prescribing's English prescribing data set sits on. So it's really wonderful data set. And that is where the data science team that I work in comes in. So we've got a really well-established data science and advanced analytics capability at the BSA. The team was established in around 2014, and our purpose has never really changed, and that is to deliver new strategic insights through innovation, experimentation, storytelling, and collaboration. So now, quickly, on to the actual work that I came to present. So this work started with my lived experience as a parent of a child with allergies. And as a parent, when you're kind of in the allergy community, you kind of listen out for stories. And I heard a really horrible story about a child that went into anaphylaxis and they used their adrenaline auto-injector device, and the dose that they had wasn't sufficient and it wasn't enough to save their life. As a parent, this terrified me, but as a data scientist, it got me thinking about the data that we have at the BSA, and could we check and see, is this a one-off, or could there be a wider problem out there, and is there something that we can do about this? So for anybody who's not familiar, anaphylaxis is defined as a serious, potentially life-threatening, systemic hypersensitivity reaction that's usually rapid in onset. The treatment for anaphylaxis in the community is a standardized dose of either 150 micrograms or a 300 microgram adrenaline auto-injector, or AAI, device. And which dose you're on depends upon the weight of the patient. There are currently no standardized mechanisms that exist in primary care to transition patients from this 150 microgram dose to the 300 microgram dose when they reach 25 or 30 kilograms. And there's a bit of a grey area there, and it's 25 or 30 depending on the brand of the AAI device that you get. So what did we do? This started with this simple question of, can we see, is there an issue here? Is there something that we can find and kind of raise awareness to? And it kind of turned into a big collaborative project working with paediatric allergy specialists at the Great North Children's Hospital. And so together what we did was we looked at the prescriptions data, and we looked between December 2022 and 2024, which was the most recent 2-year window at the time of analysis. And we identified nearly 47,000 patients whose most recent prescription was the 150 microgram dose. Unfortunately, at the BSA, we don't capture patient weight. So it wasn't as simple as just being able to say, oh, there's a patient, they're over the weight. But we do capture patient age. So we were able to use RC-PCH growth charts to approximate the patient weight from the age that we did have. And we did this at a couple of different percentiles. And then we quantified how many patients might have received what we call a non-standard dose. So for this work, we defined a non-standard dose to be patients who are likely to have exceeded that 25, 30 kilogram threshold, but they've still received that 150 microgram dose. So a little bit of background first on the kind of prevalence of AAI prescribing. We just did a little time series to see how frequent these are occurring. So we can see that it's on the rise from 2015-16 up to 2024. We can see AAI prescribing is going up year on year. And if we break that down by the dose, we can see that it's really the 300 microgram device that's driving that increase. And then we get back to our rates of non-standard prescribing. So as I mentioned, we use different thresholds, and unsurprisingly, you get different numbers of patients depending on the threshold that you use. So I kind of want to talk about this slide in reverse. So starting with panel C, at the bottom here, I don't know where the clicker is, sorry. Oh yeah, here we go. This one. So this is where we are most sure. This is the 0.4th percentile. So at this level, 99.6% of patients would have exceeded the weight thresholds. And when we look at this level, we identify around 1,700 patients that are on a non-standard dose. And while this is great because we can be really sure, well, as sure as we can be, that these patients are on a non-standard dose, it probably is underselling the problem because realistically, people start to cross those weight thresholds much sooner. So we also looked at the 50th percentile, and that gave us around 10,000 patients, so that's probably more of a feel for the scale of the problem. And then we found some Resuscitation Council UK guidance, and in this guidance it suggests that everyone 6 and above should be on this 300 microgram dose. And so if we apply that logic to our data, we can see that there are around 23,000 patients with a non-standard dose. And the majority of these are children, but actually we can see that actually goes right through all the age ranges here. So what else can we look at in our data? We can look at the number of devices that patients receive. National guidance states that patients should get 2 devices, and when we look at our cohort of nearly 47,000 patients, we can establish that over 95% of them received 2 devices or more, which is in line with the national guidance. So that was good to see. We looked at our rates of non-standard prescribing geographically. So this is the number of patients who received a non-standard 150 microgram AAI relative to the total number of patients who received 150 microgram within an ICS. And unsurprisingly, depending on the threshold, we get different rates of non-standard dosing. But what we do see is that if you're a hotspot in one of the thresholds, you tend to be a hotspot in all of them. And likewise, if you've got low rates in one threshold, you've got low rates in all of them. So the last thing that we looked at was the association of non-standard prescribing with deprivation. I've just shown the results here for our 50th percentile, but we found the same across all of our thresholds, which is that the rate of non-standard AAI prescribing is higher in areas of greater deprivation. So based on this, and with the clinicians from the Great North Children's Hospital, we came up with a bunch of recommendations. So firstly, we think that each ICS should conduct a patient safety review to identify patients in their area who are in receipt of a non-standard AAI. Secondly, by 8 years old, over 50% of children would be expected to be over the lower weight threshold of 25 kilograms, and we therefore suggest that patients are started to be reviewed from 8 years old to make sure that the dose is appropriate for them. By 14 years old, over 99.6% of children would be over the upper weight threshold, and therefore we suggest some form of automated switching processes that could be implemented into primary care systems so that anyone over 14 can get switched and we can try and eradicate this issue. I just want to very quickly thank my collaborators on this project. We've got a couple of paediatric consultants from the Great North Children's Hospital and Dr. Tom Owen, another data scientist who worked with me at the BSA. Obviously, we're not doing questions now, but I could talk about this all day. So if anybody thinks that they know ways that we can get this out further, the paper is published in Clinical and Experimental Allergies Journal, and it's openly available. But if you've got any ideas or you want to talk about it, come and find me at the break. Happily chat. Thank you.